So we're going to talk today about open ankle fractures. I don't have any disclosures relevant to this talk. I wanted to start with a case. So this is a 70-year-old male that was in a motor vehicle accident as a pedestrian. He was walking and was struck by a car that was going about 20 miles per hour. This was a case that was transferred from another institution that was about 60 to 40 minutes away. Patient before the injury was a community ambulator. The only past medical history was hypertension. As we can see here, we have a tremalleolar ankle fracture with a Gustilo and Anderson classification type 2. The wound was about 8 centimeters in length. The patient came to our institution. We took him to the OR. We did irrigation and debridement. Given that the wound was so close to the medial malleolus, we decided to do fixation in the medial malleolus. We were able to access the fracture through the laceration. And what we did was hold the reduction and perk with 2 cannulated screws and put the X-fix. The patient, given that it was transferred, we felt it was a lot of soft tissue swelling, and we didn't want to go without having a CT and go through the whole case. So we decided to put in an X-fix. The reality is, like, looking in retrospective, maybe we could have do the definitive fixation all in one stage. But that was my first thought and my approach at the moment. So as we can see here, the patient was taken to the OR about 12 days later, and we fixed the fibula fracture and the posterior mal with 3 cannulated screws. The patient was then transferred to rehab, and this is the final X-rays about 4 months post-surgery. The patient's doing well. He is slowly progressing from walking with the walker to a cane. It has been a long transition that we attribute to his age, and although he was an ambulator, it was some weakness over his extremities before the injury. So this is overall a good outcome, especially in somebody this age. So now, when we talk about ankle fractures, we see that in general, ankle fractures represent about 10% of all bone injuries, and the incidence, at least in the US, is about 187 per 100,000 people yearly. And open fractures are about 4.5% of all of them. Initially, this was more related to work-related injuries or high-energy trauma in males, but we have seen a trend, especially with the life expectancy increasing, that these average in age people with open fractures are shifting a little bit to people older than 60 years old, and usually a lot of them occur in women. So now when we have these ankle fractures, what are we expect of this population? Well, there is a recent study that we're talking about, like, what are the contemporary demographics of our population? And they describe that about close to 40% of the patients are older than 65 years. And that represents comorbidities, osteopenia, and even difficulty with ambulation. This hasn't changed much in terms of the location of the wound that is usually immediately located, and the deep infection rates are up to 25%. So even we think that ankle fractures are a little bit easier or less related to high impact in terms of disability, we can see here that as it can create significant chronic pain and even very difficult complications on long term. Up to 54% of the patients have a complication, and they require at least a quarter of the patients require more than 2 surgeries after they had their index surgery for this. Now, what are the risk factors for a patient to have open ankle fractures? As we can see here, this is a very interesting study that look at a 4-year period. They look at about 26,000 patients with open ankle fractures in the US, and they determined that they kind of divided the group in high energy and low energy groups. And the ones that have high energy group, interestingly, they found that risk factors to have open fracture were to be a female, the high index severity score, injury severity score, being older, BMI about 40, and having an injury that it was in a farm or an industry location. When we talk about low energy trauma, being a male, having, again, this is similar to high energy, having a high injury severity score, having older age and BMI over 40, which is also related to having an open fracture. So in general, we can talk that these are the red flags when we are seeing patients with open fractures that usually are related to older people, that is usually obese, and the injury is related to a firm, which can be related to a very contaminated wound. So who has wound complications in patients with open fractures? What are the patients that have independent risk factor for these? This is a multicenter study that included 16 centers, and they included about 1,000 patients with open fractures that they found that being a male. And some of these factors is not surprising to all of us, being male, having diabetes, being an active smoker, being under any type of treatment that is causing immunosuppression, having a lateral wound that I feel plays, it's a protective factor, given that over 90% of people has a medial wound, but having a delayed time in closure, where they talk about the average of more than 19 or 18 hours, it's related to independent factor to have an infection after an open fracture. As we can see here in this table, when we have a fracture that has a Gusilo classification of above 3B, the risk of infection doubles. Now, when we close these injuries, which is what we probably do at least over 90% of these patients, what are the predictors to have necrosis? So it's not only closing at the first surgery, but what is going to happen after? Well, this study included about 130 patients, and they found that the incidence of having necrosis after a primary closure is actually about 18%. So we're talking about that close to 20% of patients might have this type of complication. And when they look at the risk factors, they found that patients with anesthesia classification ASA 8 more than 2, Gusilo classification more than 3, and those that were use pulsatile lavage at the index surgery has a higher rate of necrosis of the wound. And the authors in these papers even mentioned that they're concerned that recommending to maybe do not close primary Gusilo classifications type 3B and type 3C. And when we look at these fractures that are increasing over time in the patients that are older are actually having more of these, we want to look at what is the mortality rate and how many patients after an open ankle fracture that are older than 60 years old actually can die of these. So as we can see here, there are some studies that try to look at the risk factors for these. And there is an article that includes only patients with fractures that were older than 65 years old. And they found that the risk factors to return to the operating room were having a type 3 ankle fracture and having a definitive external fixation. In terms of the mortality rate, at 1 year mortality rate, factors like age, which it was being older than 70 years old and being a minimal ambulator, or having multiple comorbidities that they mentioned about over 3 are related to increased mortality at 1 year. And when we look at the long term of some of the patients, these articles show us that the 1 year mortality can go up to 23%. And risk factors that are related to having to die after an open ankle fracture in the elderly population are to having at least one complication, which is relatively easy in this type of injuries when more than 50% of the patients have at least one complication, have a definitive external fixation, no definitive enclosure in the first surgery, no being an independent ambulator, and having diabetes. Now, does the type of fracture matter? Is actually this causing worse outcomes in patients with open ankle fractures? Well, there's a few articles that are looking at the type of fractures and see what is the relationship between these and the outcome of the patient. And as we can see here, these authors describe that people with or patients with open pronation, abduction, ankle fractures are associated with a high BMI. And these patients are having higher number of complications requiring, in some cases, a salvage procedure that include fusion, or in the worst case, even below-knee amputation. And there is a trend towards higher rates of deep infection, especially in patients with high BMI. Now, when we look at surgical site infections in patients with open pronation, abduction, ankle fractures, we see that the numbers are not very low. The superficial surgical site infection goes up to 16%, with deep surgical site infection about 10%, and the risk of below-knee amputation that goes about 2% in this study. They also report increased incidence of fibular union or implant failure or collapse of the tibial platform. So now we want to see this case, which the results were not as positive as the first one. And this is a 57-year-old man, actually no past medical history besides having a hepatitis C virus infection in the past, who was struck by another vehicle, and it was involved in a motorcycle accident. The patient, besides this injury, had some laceration above the elbow and the hand, and it came to our institution with this picture and this fracture over here. We classify this as a type 3A. And we took the patient to the operating room, did integration and debridement and definitive fixation. The patient wanted to stay for about 72 hours of antibiotics, and then we'll send home to start rehab. I think this image was from the previous case, and I apologize for that. So now the patient continued with multiple courses of physical therapy, always complained of pain. He never got more than 30% or 35% improvement in symptoms. He keeps complaining about pain. At that point, about 7 months post surgery, the decision was to remove the syndesmotic screws. CT was taken to make sure everything was healed, and the patient did not improve. There is no significant improvement. Interestingly, he always complains about the pain, most over the lateral side in terms of the tibia and the lateral gutter. And given that he is not getting any better, I decided to take an MRI that shows osteonecrosis of the distal tibia. At this point, I offered the patient to undergo an ankle fusion. However, the patient decided that he wants to wait, he wants to try a brace and all conservative treatments before undergoing surgery. Because we can see here that the pattern of this injury was relatively benign, with only fibula fracture with the syndesmotic instability, and that with this very poor outcome in terms of mobility and functionality for a patient that is only 57 years old. In conclusion, ankle fractures are having an increased incidence in terms of patients with low energy trauma in elderly patients. And I think all of us have these type of patients in our centers, not only level 1 trauma centers. Open ankle fractures have a high mortality rate, especially in the elderly population, and there are some authors that are comparing these to the mortality rate similar to hip fractures. So I think we cannot underestimate this. Total lavage in the index surgery should be abandoned, and I think there are multiple articles that have shown the association between this and deep infection. Internal fixation and primary wound closure has been associated with better outcomes, and I think every time that the patient is suitable for internal fixation and a primary closure, we should try to do it. Open pronation, abduction, ankle fractures are associated to higher complication rate, especially in obese patients. I think obesity, higher BMIs, has a strong relation with wound complications, not only in open fractures. But once again, this has confirmed in these type of injuries. Thank you. And I'm gonna stop.
Thank you very much, Lorena. That was a fantastic presentation. I just have 1 or 2 questions for you. With regards to, it was good for me to know that the mortality rate of ankle fractures actually compares to that of patients with hip fractures. That's something that I did not know. But what determines whether or not you'll primarily close the wound? Is it the predictors of necrosis of the skin or any other thing that you use to to determine whether or not you will close the wound?
Can you repeat the question, please?
Sorry, I was asking what determines whether or not you will do a primary fixation of the ankle fracture rather than a delayed fixation of the ankle fracture. Is there anything that, apart from the predictors of necrosis of the wound, any other thing that would determine whether or not you'll do a primary fixation of the fracture?
So I think the type of fracture in terms of the Gustulo classification, if it is 3B, then is a a 3C that is a flap, or 3B if there's a patient that has significant swelling, I probably would be more cautious. Any type 3A or type 2, I will always push to close the wound, especially if we're taking the patient to the operating room the same day that the patient had the injury.
All right. Okay. Any questions, Dan, for Lorena?
No, I mean, I think everything she went through was fantastic. Great talk. Yeah, I mean, I think that the biggest thing to try to figure out is, what to do with the wounds. I mean, the bony injuries are typically not as horrible as the soft tissues are. So wound management, I really think, is the key, and just trying to figure out like when to close, when not to close. Do you do another debridement? Do you come back? I think that's I always explain to my residents that that's the hardest I think that's one of the hardest things to figure out in orthopedics, especially, when we're dealing with some of these open injuries and how to manage the wounds. Different centers too, like what's your soft tissue surgeon, plastic surgery, are they aggressive? Are they great? Are they good at what they do? Do you have to struggle to get coverage? So I think a lot of that makes you maybe get a little bit more creative when it comes to fixing and managing these wounds. So, but no, I think that was great.
Yeah, I agree with
right,
you.
Dan,
And I think also, I also think that, as you said, it's interesting because it depends of the scenario when these fractures are. I think knowing if the fracture was related to in waters, they were like gross contamination, those things should be always be taken in consideration if we are thinking about doing a second irrigation and debridement.
One last question, and this probably may not relate to where you are, but certainly I'm in Nairobi, Kenya, and a lot of the ankle fractures that we see usually come delayed. So even after 24 hours, would you have 24 hours as a cutoff point from which you will not do a primary fixation in terms of timing when the ankle fracture comes?
I think it depends. It's how swollen the tissues are. Like, let's say that if the patient it has a type of like 2 ankle fracture and has been immobilized, and antibiotics have been started within the first ideally 60 hours, even if they came to the center where they're going to have the surgery late. I might consider to do at least or a partial internal fixation if it is not right where the wound is. But if it is significantly swollen, or if through like the injury, like the open laceration, I probably would be more cautious. I don't know what Daniel thinks about it.
Yeah, I mean, like I said, I think I try to work through the open wounds if I can. Like that first case you showed with the external fixation and that medial malleolus fracture. I do exactly the same thing. My goal is to try and get it reduced, fixed, at least on the open side, and then closed. Just because you find having to go back through those wounds is when you get into trouble. And then just once you've done that and it's stabilized and temporized, coming back once the soft tissues are amenable, from a swelling standpoint, I think is the way to go. Something beyond 24 hours, that's a little bit more concerning for me. So we'll wash, try to, assess the soft tissues, assess the wounds, temporize with maybe an external fixator, and then, or minimal fixation, just like you said. And then at that point, try to just see what the evolution of the soft tissues are.
Okay, good. Well, over to you, Dan. Sorry, I mispronounced your second name.
Oh, it's okay. It's pronounced Dziadosz, but that name is a challenging one for sure. So, so just to kind of continue on with the open ankle fractures, just want to kind of go over goals, initial management, just like Dr. Pineda talked about, timing of fixation, and obviously management of complications. Ankle fractures do have a high rate of complications, so managing the issues that can occur post-operatively is always a challenge. I'd like to start off with a case. This is probably a young, healthy 29-year-old male who fell while rock climbing. No past medical history, and more importantly, especially from where I work, as no toxic habits, so no tobacco, no illicit drug use or alcohol abuse as well. He is domiciled, so that helps too. So this is how he presents. This is that lateral open wound, and minimal, bony work especially, but mostly soft tissue. And we see almost a complete circumferential laceration with exposed distal tibia. So, now the question becomes, what do we do? How do we manage this? What are our first steps? So, just kind of, we'll come back to that case in a bit. Just want to kind of go over some of the basics and kind of my thought process on how we do this stuff. So, as was said earlier, the majority of these wounds are usually kind of higher medial transverse wounds with exposed bone. So my big thing is, when I'm coaching and educating the residents, management of this wound in the emergency department. If there's gross debris, get rid of it. But ultimately we want to reduce these injuries. Take the tension off the soft tissues, take the tension off the neurovascular structures, get them splinted, and ultimately antibiotic prophylaxis, first generation cephalosporins. Sometimes we'll use aminoglycosides, and then obviously penicillin for gram-negative coverage, and obviously tetanus booster, or if they're unsure, we can give the full tetanus profile. And then, situations that are amenable, emergent surgical intervention. Now, the thing about surgical timing that we find is, soft tissues dictate this. And as was said earlier, working through that open wound is kind of my mainstay of treatment to get things stabilized. And then if I have to delay to come back, if the soft tissues, if I'm at all concerned, I'm going to delay. I think the better part of valor is to delay on these injuries. The other thing too is, as we're talking about, the higher number of elderly patients that we see that have these injuries requires coordination of care. General surgery for our trauma patients, the ones that are severely injured, but, medicine, cardiology, nephrology, trying to coordinate all of these services to make sure that the patients are optimized prior to going to the operating room. I know it's an open injury, and we want to, sometimes we have like a one-track mind with getting things taken care of, but looking at the patient as a whole, I think is paramount to good care. And so we want to make sure that all the things have been done, in a proper manner to make sure the patient has the best possible outcome from a medical standpoint. We can deal with, ankle arthritis, we can deal with, some of the infections, but if someone has some type of massive cardiac event that was undiagnosed and it happens in the operating room, there's not much we can do after that. And then, like I said, trying to push to get things to the operating room as early as possible, but mostly as safe as possible. And then we're kind of touching base on this early definitive care. There were kind of two protocols. This study out of JOT in 2020 looked at two protocols, that early versus late closure of wounds. Things were similar rates of infection, obviously shorter hospital stay, because in this cohort, what they were doing was washing, stabilizing, and then leaving them open and coming back in a delayed fashion to close. Now, do I think there is a role for that? Absolutely. Like you were talking about, some of those delayed injuries that present to the hospital or transferred in 24 to 48 hours later. But they also showed that the outcomes were similar in these two cohorts. So early versus late closure is a very reasonable option to close these wounds and move on. Now, as far as our surgical objectives come, I kind of break these into two two sets of objectives. We have our soft tissue objectives, which is obviously paramount. Working through the open wounds. We want to limit overlapping incisions. So, proximity, we always kind of harp on the proximity of one incision to another, but I think more importantly is the overlap. What percentage of each incision is overlapping the other in a shorter distance? So using smaller incisions like a percutaneous incision to place a clamp or to place a screw for, say, you have a Chaput fragment that needs to be reduced. And the other thing too is I'll adjust some fixation methods to accommodate open wounds. If someone has really bad soft tissues, if they're a vasculopath, maybe I'll use an external fixer, but maybe I'll use a fibular nail, maybe, percutaneous fixation of the medial malleolar structures and the syndesmosis if possible. Maybe my reduction may not be perfect, but at the same time, we can deal with imperfect reductions and arthritis way better than we can have somebody who may need an amputation because we put a big open wound that we can't get closed and there's really no options for soft tissue reconstruction. And then now some of the the bony issues that we talk about. We want to eliminate our talar shift, restore our mortise, establish articular congruity so we can start functional range of motion early on. And like I said, always respecting those soft tissues. Now, as we talk about managing some of these complications, the biggest ones we see: infection, soft tissue breakdown, the non-unions, the malunions, and the impaired functions. Like, I kind of break these into two classes, right? The top two are the most paramount that we deal with. The later three, we have many solutions for, but like I said, the soft tissues are so critical in these open fractures. This was reviewed in the previous talk about the different things. The male diabetics, smokers, immunosuppressant, where the wounds are, I think are really important. And I have a good example of that. Actually, I'm actively dealing with now. It's kind of funny as I put this case together. My resident actually called me from an outside hospital to tell me that this patient showed up in his ER again. So this one is, not quite open, but really very close to being open. He was a 43-year-old, tobacco abuse, schizophrenic, undomiciled. So, that support network is very limited. Soft tissues initially look okay, as you'd imagine, kind of stress and strain on that medial soft tissue structure, as was shown. But we kind of follow the protocol: emergent reduction, which looks pretty good. Not much in the way of a bony injury, but like we said, a lot of these are soft tissue management. So I said emergent reduction, closed fracture, but we allowed the soft tissue swelling to resolve 7 to 10 days. And then we took the patient to the operating room to stabilize, long lateral base plate, and then fixation of our medial structures to help restore the articular congruity. When we saw him back 2 weeks, was looking good, and then he disappeared. He was seen at an outside hospital, I think 3-4 weeks later. This is what his wounds look like. As we'd imagine, this medial soft tissue has that necrotic look. The lateral side not looking the healthiest, and then ultimately he shows up back to our ER 10 weeks post-operatively with exposed hardware. All right, so now the big question is, what do we do? Well, this is where, for me, the way we have our arrangement with our plastic surgery service is, we'll do the initial debridements on these folks and get them to the point where, the soft tissues look healthy, and then this plastic surgery rides in on their white horse, and they'll do their magic to provide soft tissue coverage. So we use negative pressure wound therapy dressings a fair bit on these. And so they did a local propeller flap for this patient, and looks pretty good. It's our immediate post-operative pictures, kind of daily look, daily appearances. The big thing to stare at is this distal aspect of the wound. It looks a little congested, and that's going to kind of play a role in this in his care a little bit later on. But proximally looks very healthy and looks good. And then same thing here, looks really good. And if we can kind of focus in on this distal aspect of this wound, you're going to see that's the issue that we're dealing with now. When we saw him just a couple of weeks ago, that was the part of the wound that was dehiscing. We recommended admissions for debridement and plastic surgery intervention. However, patient expressed his wishes to not be admitted. And then, 2 weeks later, has surfaced at another hospital, and we're trying to get him transferred. So, the question then becomes, where do we make our incisions? How do we make our incisions? And there was a study that came out of our institution a few years ago that looked at the use of the laser-assisted indocyanine green angiography to determine surgical incision placement. So this is the scan that you'll see that the plastic surgeons often use when determining soft tissue reconstruction and placement of free flaps or local propeller flaps. And so they over the course of 5 years, we looked at these open ankle fractures and scanned them. And so maybe avoiding some of the regions where you would typically place incisions could to help prevent some of these complications. This is just a picture of someone who had this anterior lateral wound, and clearly there's really no good angiosomal blood flow distal to this wound where we would make an incision. You just start to see flow the dorsum of the foot, which is most likely collateral flow from the plantar aspect. So you have to be careful as to where we put this, place our incisions. And if you have access to the SPY, then I think it, probably something pretty reasonable to use in some of these complicated cases, just so we can avoid, things like I had just shown. So, but as we work back to our case, our 29-year-old male fell. This is a healthy one. So we luckily had a successful outcome with this one. Got him reduced, splinted. He, like I said, this is kind of an atypical pattern. He didn't really have that high medial transverse wound. He had an open lateral wound. His syndesmosis was intact. So this is the majority of this was a ligamentous injury. But the ominous sign of it, as we go back and we look at his wound, was the damage that was done to both the talus and the tibial plafond. So maybe this may not manifest as a wound issue now, but I think down the road we're going to be seeing him back with some arthritis and some stiffness and some trouble. So underwent emergent reduction. He had first generation cephalosporin. He got Tdap and the ED. Here's what his initial reduction looks like. So as you imagine, when the talus moves back into the plafond, underneath the plafond, it looks pretty good. And so our operative tactic here was, working through that open wound to evaluate plafond and talar dome, debriding all our non-viable tissue and the cartilage that was just without any subchondral connection, assessing the ligaments, understanding what's been torn and what needs to be repaired, and then just doing periodic stress as you go and sequentially repair medial-based ligaments, and then obviously coming back to do some of the, making a separate incision to fix some of the lateral-based ligaments. Unfortunately, he had also torn his perineal retinaculum, and that needed to be repaired. So this was our intraoperative fluoros, and then as we had started range of motion but kept him non-wavering, this is our 3-month X-ray, still maintaining his reduction. But as you look close enough, you can start to see some of the talar dome cartilaginous loss and some of the maybe that the medial gutter doesn't look perfect. So, but like I said, so this is one of those where maybe a win in the beginning, but this is going to be a long-term problem that we'll deal with going forward. So, if there's any questions, fire away.
Just maybe one question, Dan. I'm just wondering, what's been your experience with this percutaneous fixation? Because you acknowledge that you may not be able to get a perfect reduction, but you can deal with the complication rather than the skin loss.
Yeah.
So what's been your experience just with the outcomes?
So I reserve the percutaneous fixation for some of those like older, lower demand folks who really have bad vascular issue. To be perfectly honest, they've done reasonably well. They're, like I said, they're lower demand. So for me, it's to maintain plantigrade ankle, keep them splinted and not weight bearing probably for about 8 weeks, give them time to at least heal, and then start them slowly on the road to recovery using a boot, a removable boot for ambulation, probably for another month. So probably by about 12 weeks, I get them, without a boot, but they're using assisted devices. And to be perfectly honest, they've done reasonably well, mostly because of their low demand. It's like if it's a young, healthy, active person, then obviously not the choice I'm going to make, but somebody who's, in their 80s, diabetics, folks that need assisted devices for ambulation, those are the ones that I'll go with.
All right. Any other question for that? Well, then I think we'll proceed to our last presenter, who is Rajeev Vohra.
Can you hear me? Can you hear me?
We can.
Yes,
Hello?
we can hear you.
Yeah, we can hear you.
Thank you. Thank you so much. I'm very lucky that the previous speakers have already laid down the foundation of the management of the open ankle fractures. And I do agree with most of them, what they have said. So they come in, the two lots, that's the high energy injuries in the younger patients and low energy injuries in the elderly patients. And whether to do an immediate fixation or the stage fixation, it is well shown in the literature. Whenever it is possible, we should try to get early skeletal stabilization, and preferably in the form of internal fixation if the soft tissue permits. And my previous speakers have already highlighted that up to 3A wounds that they are happy in doing the immediate internal fixations. And this is exactly the strategy which I am following. And wherever I feel that I get a primary closure within preferably 72 hours, then this is the the cutoff point that I like to do the immediate internal fixations. So many papers in the literature which show that you can do an immediate fixation, and this is just a repetition of some of the things way back you see in 2084, 2010. But important thing is again the soft tissue handling, which has been again very well stressed. And my previous presenter has been repeatedly using the word that working through the wounds, and I perfectly agree with him that I also like working through the wounds than making new wounds or something like that. And you need to have an ample bridge between the other wound if you are creating. So with this thing in mind, that we can go ahead with the with fixation, and patient should be taken into theater within 24 hours. This was one question our moderator asked. But what I do is in my setup, it is not the 24 hours which matter, it is the wound condition which matters. Maybe if sometimes there is a 2A or 2 wound 2 or grade 1 or grade 2 or even 3A, if you think that the patient is coming even after 24 hours and the wound is good and you need to debride it, you take the patient to the theater. If the patient has a good wound, then you can even go immediate internal fixation. It is not the time frame, it is the soft tissue conditions which actually dictate the treatment. And I am very much concerned about the degloving of the skin. That to me is the most important factor when I'm looking into the open wounds. If there is a lot of degloving, the wound may be small, but this degloving, beware of these wounds. So I always try to really find if this degloving is the most important factor when I take the soft tissues into considerations. So now with this, that the early fixation can be done once the soft tissue is good. I'm not going to repeat these articles again and again. And again, the factors which have been associated with infections are again. This is again the same paper. So I'm not going to do the predictive factors which have been well discussed. So I'll just skip these. So I'm just lucky that my previous, of course, I re-emphasize that I don't use pulsatile lavage anymore, and it has been well proven that pulsatile lavage is, detrimental to the soft tissues. So I avoid using these. So then other thing is, it is not the size of the wound which matters. It is the condition of the wound. And there are conflicting reports whether the diabetes is going to affect your treatment or not. But of course, I'm too cautious when the patients are diabetics, and you have to have a consultation with your physician, your diabetologist, and the cardiologist, and so that to find that the patient is fit for the surgery. So this is the same old. So definitive fixation can be taken. So I think I should directly move on to the cases, because these things have all been discussed well. So this is a 38-year-old male with a isolated injury to the foot following MVH, and he didn't have any comorbidities. You see, the wound is quite a big wound, and everything is coming out. But actually, on debridement, we found that the wound was reasonably good, and this is the X-ray which is showing you have a posterior malleolus here, you have an anterior malleolus here, you have then the fibula, everything, and then on debridement we could get a very good wound. And now we could actually space the incision. So we just went on for fixation. We did a posterolateral approach through which we could take care of the posterior malleolus. We could take care of the lateral malleolus, and then we made a small incision entirely to take that Chapuis fragment, and then the medial malleolus was handled through the wound only, and this is what we could get after the surgery. We could close everything, and then we had a very good healing in this patient, and it went on to heal very well. So mostly you have a medial side tension wounds. This is the lateral wound, which are known to be notorious, and it is a 21-year-old male who just reported 4 hours after the injury, and he had an associated fourth metacarpal fractures. So then we again debrided the wound. We were happy, and we went on the medial side, gave a separate incision to handle the medial malleolus, and then exactly working through the wound, you see, we did a percutaneous fixation of the lateral malleolus and used the skin graft for that wound. And this is what we could get. You see, the graft has been taken up, and this is the range of movements we could get in that patient very easy. This is the so that was 5-year follow-up of that same patient. Now this is another probably it's into a pilum fracture, but it is an intra-articular sort of injury. So in this case, when you have a diaphysis as well as the intra-articular injury, we just stabilize the this articular component, and the diaphyseal component was stabilized with X-Fix, and this was what it was done. And after that, then I'm sorry, there's some jumbling of the slide. Then the flap, it was taken, and once the flap was taken up, we removed the fixator, waited for everything to subside, and then did the fixation. And this is the result. We could sorry, this is the result we could get in this patient. So there is some jumbling of the slides. I'm going to back to this patient. There is a 60-year-old male, again a motor vehicle accident, and so the true transverse wound in this patient, and you see the energy is a diabetic, and but no other systemic problems. So what we did in this case was, uh, we again went and did the internal fixation, working through the wounds, made a separate incision for the fibula, and we just closed one incision, and the other incision was skin grafted, and this is the range of the movements in this patient we could get. He went on to healing. And sometimes you have really big problems. Both the limbs were affected on the one side because we really had to do the amputation. So it was really a challenge whether we should go and preserve the ankle or the limb on the other side. So our plastic surgeons took the charge, and we just stabilized it temporarily and did a local flap, and we tried to do a primary fusion, but unfortunately we couldn't achieve it. So at the second stage, when everything had healed, we did an ankle arthrodesis, and we were able to salvage the limb. So I think if you're really if you're ready to take that load, and you understand the soft tissue conditions and how you have to work through the wounds, and well anticipate which patients are going to having problems later on, so we can do internal fixations a little quite early and give good functional results to the patients with open fractures. Thank you so much for this, and I'm open to any questions if there are any.
Thank you very much, Rajeev. Much appreciated for your talk and for all the complicated cases that you've had to deal with. Similar cases that we deal with here in Kenya, because we just work in a very resource limited setting. So thank you very much. Any questions for Rajeev from Dan? And any questions?
I'm just curious, since Dylan and I are practicing in the same country, but other speaker is not. Are you putting any antibiotics when you're closing these wounds? Like there's a trend to use vancomycin, but I'm just curious.
So in grade 1 and grade 2, if you are happy with the debridement, we don't use it. But definitely in grade 3A, we don't hesitate in putting. So it is just a soft tissue condition. But if you find the contamination is more, I do use these vancomycin.
What about you, Daniel? Are you using vancomycin?
Yeah, I think probably for some of the dirtier wounds that I'm concerned about, we'll put it in at the time of definitive closure. But I don't do it too much. I'll typically leave my patients on IV antibiotics as long as they have good blood flow. I'll leave them on antibiotics for maybe for 48 hours after some of these real bad wounds. I'll use the VAC dressing a fair bit too to help with some of the soft tissue swelling and soft tissue management. So
like incisional VAC?
Yeah, I'll use incisional VACs. The other thing too that I've used for some of these real bad dirty wounds, I've used the Instill VAC that actually will pump antibiotic fluid into the wound, let it set, and then it'll pull it back out. I've used that probably half a dozen or a dozen times for some of these really bad open players that have that just are infected and we can't get them clean. I feel that actually cleans them up pretty well after a few days of the Instill. So
that's the same what you're saying. That's how I do the things. I don't routinely use the vancomycin on all. It's a wound condition and the contamination which dictates whether I'm going to use it or not.
Yeah, I think in Kenya, the number of spine surgeons have actually advocated a lot for use of vancomycin. It's not taken up in other subspecialties in orthopedics. I've used it a little bit for open fractures, but not necessarily for open ankle fractures. Any other questions?
So I think the implants which I have shown are little not maybe not up to the mark as far as the developed countries are concerned. So we are using a very whatever limited resources we have using the recon plates or something like that, not a very thin profile plates, but that is our constraint, the money constraints we have. We have to use on presentation, these implants may not look that impressive, but if you really follow the principles of you taking care of these open fractures, and it is really, you can get away with these implants. It is not the implants which actually matter, it is how to use these implants, it's more important. So that is what I want to convey. So these may look a little crude implants, like I'm using a lower end radius plate for ankle arthrodesis, and which I've done more than 100 cases. I just bend those simple lower end plates to give that curve and to achieve the union, and then placing the implant at the right, like in the fibula, I'm very fond of placing the implant on the posterior aspect than on the lateral, because I find that is the place where you can have a breakage of the bone. And I do understand that some of the speakers may be having some concerns regarding the peroneal tendon irritation, but I have done more than hundreds of them, and a very few have been reported. So your implants get protected with the soft tissues. We need to understand that when we are managing the open fractures, your implants are well protected by the soft tissues. And if they are not well protected by the soft tissues, you or your plastic surgeon must be able to give the cover within, let's say, 48 to 72 hours maximum. If you are confident that you or your plastic surgeon is going to take care and provide the cover, we should go ahead with the internal fixation. Otherwise, if we think that we don't have the facilities to do it, the expertise to do it, or the wound factors are not that good, in those cases, we should try to do the stage treatment. Let's see how the wound behaves with the time, and when we can cover it, once we get the adequate coverage, and then do the secondary reconstruction.
Thank
Any
you
other
very much,
comments?
Rajeev. From my vantage, yeah, so thank you very much, Rajeev. From my vantage point, those implants are not unusual, because when you work in a resource limited setting, you use what you've got. Any other comments? All right, well, I don't think we have any other comments. Maybe we'll get an early break before the next session. I just want to reiterate some of the points that were mentioned in the discussion, that if you can go for a primary fixation, then you go for it, but you need to work through your wounds, and that you need to be careful in older persons, because they can have a higher complication rate. And you can get good outcomes if everything is done well, but always prepare for another surgery just in case you get complications. And you always need a multidisciplinary approach. So you'll always need the plastic surgeon sometimes to bail you out if need be. Thank you very much for your time. Really
I
much
just
appreciated.
want to ask the panelists. I don't have. Do they have any experience in using fibular nails when in these patients, particularly in the elderly or something like that? Anyone has got an
I
experience
don't,
with fibular
I,
nails?
I don't, I haven't used I've used fibular nails periodically, but I use just a simple 3-5 like screw, like a long pelvic screw, like 110 or 150 millimeters, depending on fracture. Yeah, I mean, I saw, I know the session before they were showing like tibia fractures and using the fibular nail. I think it's a reasonable option for some of these who have, like I said, soft tissue limitations. So
I have
Cost,
used it
money
in
is
cases.
good. Yeah, please carry on.
Usually are older patients or with a lot of concerns for wound complications, usually they don't have any open incisions, like all the wound is medial, and the fracture, it's a simple fracture. There is not a lot of comminution in those cases, but it has been very particular. But as Daniel says, I feel like you can put one screw, like 3.5 screw, long screw, if you can gain the appropriate length of the fibula in those cases. And I don't think there is a significant difference between that and using the nail.
Unfortunately, I don't. Okay.
I think Selene is there, so our time is probably.
Yeah. Hey, guys. I wasn't able to welcome you to the session. Thank you so much for doing this. Thanks, Smith and Nephew, for sponsoring this session. Great experience, great cases. I really do appreciate it. Sorry I couldn't welcome you at the beginning. I got tied up.
No worries. Thanks, Selene. Thanks for having us.
Yeah, no, I appreciate it.
Thank you.
Thanks.
Cool.
Thank you, Selene. Thank you.
Thanks, guys.
Thanks to all of you.